Okay, guys, we're just starting soon right now. Guys, if you are on Facebook and you can hear me, please, guys, let me know. Thank you. Okay, guys, we're just starting soon right now. Guys, if you are on Facebook. Okay, guys, if you can hear me, please, guys, let me know on Facebook. Thank you. Just so know I'm alive there. Yeah, I can see Dr. Mariam right now. She says, hello. It means I'm live in the Facebook, which is great. Okay, let's check on Zoom. I believe I need to admit everyone on Zoom, right? Here in this window, I cannot see any chat, but I can see here. Yep, I can see also Dr. Shriyanka, which is great. Guys, am I audible, please? Guys, if I'm audible to everyone, please let me know. That's great then. Dr. Taslim as well is here, which is great. Dr. Tulshani and Dr. Rabia. Okay, seems like I'm live and audible to everyone, which is great. Dr. Shriyanka as well. And Dr. Telji. That is great then. Okay, guys, this is very good then. So I believe we can start right now. So guys, before I start, I would love to say hi to every one of you guys. Our champions on Zoom, and also our champions on the Facebook, and then our champions on YouTube. Hi, Dr. Shashank, how you going? Dr. Hind, how you going? Dr. Mariella, how you going? Dr. Nithi, how you going? Dr. Deleb, Dr. Harpreet, Dr. Alwina, Dr. Nashilani, Dr. DT Damish, Dr. Daljit, and every one of you guys. Okay. So today, we're going to discuss the last and the most important mock. Why the most important? Because from this mock, you will learn lots of concepts, and these concepts directly related to your exam. And I believe you're going to get most of the exam concepts from this mock. If you really understand what we discuss here, I believe the new question you're gonna get in exam will be not that difficult, will be very doable, and shouldn't be hard on everyone at all. Guys, we really care about you, and I know the time is very tight, exam is very soon. However, we did another mock in very short time, and maybe we're ready to do a third mock as well. If this is going to help you, I know most of you right now say yes, I'm sure about this. If I go here to check you there, to check your comments, I believe everyone say yes. You see Dr. Taslim, yes? Love the mock, Dr. Bido. Thank you for taking the time to do it for us. Thank you, Dr. Dandini. It's my pleasure. I always guys love to help every one of you. As I always say, you are you are the source and the reason of my happiness. So your success is always makes me happy. Always makes me happy. Okay, that is good then, guys. Mock was actually beautiful. Thank you very much, Dr. Arsh, for saying this. It's my pleasure. Even when we discuss it right now, you'll see it's very nice mock and you'll learn a lot. Anyway, guys, I believe that is enough way to everyone to join us. You know, always in my sessions, I wait for some time to ensure everyone joins because I know some of you, they may have some connection issues and they may need to fix their connections. And that's why I care on everyone and I wait for sometimes. For me, I always before the time, waiting for everyone. Anyway, for our champions, our session tomorrow is, I think, you know what? Give me 1 second, please, guys. I need to do something. Guys, I will stop sharing for a second. Give me 1 second, please, guys. Okay. I will stop sharing for a second. And then just stop sharing. That will not affect anything at all. And then I will reshare back again. Nice. Can you see my screen right now? Please, guys, if you are in Facebook, I believe you should see my screen right now. Yes, okay, that is great then. Okay. No, don't show me this again. You shouldn't show me this again. Ah. Hmm. Okay. Yeah, I think that should be the one. Let's see. Okay, guys. Ready? Guys, are you ready for... Guys, are you ready right now to answer the mock? Yes? Good. Very good then. So guys, if you are in Zoom, and then would you like to share in the discussion? That will be great then. Wow, someone scored 92. Who's this? Who guys got 92? Wow. Even if I'm scared by myself to get 92 on my own. Good. Good job. Dr. Arshino got, wow, 92. That is great job. Sorry, guys, she's crying, guys. I didn't get 92. I think, guys, she's afraid someone envy her. Okay, Dr. Arshino, that's okay then. You will get 92. Anyway, guys, that's okay then. Okay, guys, first question. Guys, before I start this, tell me, please, guys, how did you find the mock? Guys, how did you find it? Was good? Okay, that's good then. Tricky, I'm happy to this. So we can learn lots of stuff right now. Good mock? Okay, very good then. Easy but challenging. I'm very happy to this. Difficult? That's okay. Different opinions. That's okay. Easy till I saw my result, but good. Okay, difficult, tricky. You know now, guys, what happens in it, okay? Let's start. I'm again to this, and then share again, and then share from here. Now, because in the same time, I need to check your answer as well. So, guys, the first question, Duna. Duna, as you see right now, she is 34-year-old woman. Attends with her 7-year-old daughter, Sarah. She is a great patient. She requests extraction. 1-8 because this one goes badly decayed and has it's hypercementose too. She is asthmatic on corticosteroids. So straight away, do you think, guys, the patient immunocompromised or not? Just let's say the word, use the right word. Most likely, that's the right word. Most likely, this patient is immunocompromised. If you are not sure, you need to check with who? With someone being on corticosteroids for asthma, right? Means she is most likely immunocompromised. To confirm this, you may need to contact, let's see the answer, to contact GP. I'm happy with this. That is great. There's the first keyword. That's the first key word. And then she has history of gastric bleeding. That's a second important keyword so far. And then both of these two keywords related to medical history, it means it will affect mainly two important things: medical, to medical, right? Now, the medical history, corticosteroids, immunocompromised, means it will affect the medical. Which part of medical? Antibiotics. Seems like this patient's needs for antibiotics. Medical to medical. Now, patient has gastric bleeding. Medical, relate to medical. What sort of medical? Analgesic. We cannot prescribe ibuprofen or most of non-steroidal anti-inflammatory drugs, mostly ibuprofen. But there is only one medicine in this group we can prescribe. What you guys medicine in this we can prescribe? Which analgesic, guys, and non-steroidal anti-inflammatory can prescribe? Siloxib. Very good. My question regarding non-steroidal anti-inflammatory, right? So because the patient has gastritis, guys, how we name Siloxib in our Bido bites? How we name Siloxib? Gut friendly, right? We name Siloxib, guys, in Bido bites the gut friendly. Good, you got the point. I'm happy. Let's now move on the question itself. Now, while extracting 1/8, you hear a crack, and notice that the segment of maxillary tuberosity has fractured and attached to the periostem. Now, we have keywords related to the scenario and the keywords related to the questions, like this one, and the keywords related to options. So guys, do you think the keywords only in the scenario, or the keywords only for the questions, or the keywords only for options, or for all of them? What do you think? For all of them, right? For both, for all of them. Very good. Not only for one, for all of them. I agree. Now, the keyword of the question is attached to the periosteum and with bleeding. What does it mean? Attached to periosteum means I can preserve the fractured tuberosity as long as it's attached. If the tuberosity is detached completely from the bone and from the periosteum, in this case, I have different options. It can be, look guys, that's very funny. This one, it's not funny, but it's actually very interesting. You can put it back again on the socket if it's completely detached. So now, let's say we have two situations: attached to periosteum or completely detached to periosteum and bone. In this case, the first one, as long as it's alive, because there is bleeding. So in this case, what you can do is you can preserve the tuberosity by stabilizing the tuberosity in position and do mucosa sutures. This is the first one. The second one, If it's completely detached, in this case, what you need to do is you put the tooth back again in the socket, stitch it until it heals for some times, and then you can extract it later on. Or you can today, if you can release it from the bone completely without complete bone loss, in this case, you can extract it, you can remove the tooth today with the bone. Anyway, what do you think is the right answer for this question? Is it A, B, C, or D, or E? We have only two things. Either to stabilize it, sorry, three things. If it's attached, we need to stabilize. Not attached, you can put it back again the socket, right? And then stabilize it, and then later on you can extract it. Or you can just, because it's really very major, it's really very major complication to break the tuberosity for the denture in the future, if required denture in the future. Sometimes even breaking tuberosity can result in oral answer communication. That's why we need to avoid it. Let me guys check your answer. Answer is C. C, Charlie. C, Charlie, repeat second, please. I will repeat again, Dr. Arouj, okay? So what I was saying is, you have two situations. One, attached the tuberosity, the fracture tuberosity is attached to periosteum, or completely detached. If it's attached to tuberosity, preserve the tuberosity. If the tuberosity attached to periosteum, preserve the tuberosity. By doing what? Stabilize the tuberosity in position with mucosa sutures. If it's completely detached, you need to extract the tooth later on by placing the fractured tuberosity back again in position, and then suture it, keep it for some times, right? And then extract the tooth. Or just extract the tooth with the broken tuberosity and then don't preserve it today. So the right answer is C, Charlie, for this question. Next. While managing the fractured maxillary tuberosity, which one of the following is the most appropriate next step? Guys, what think is the right answer? Given that the patient has no allergies to animal products and no cultures restrictions. A, stitch with the mucosa with resorbable polyglycolic acid. Stitch the mucosa with resorbable polyglyctin. Ask the assistant to bring the jockey forceps. Change to sterilized gloves. Stitch the mucosa with resorbable chromic guts and smooth any sharp bone. D delta, D delta, D delta. I'm happy with D delta. Very proud of you guys. You did the right thing. C, Charlie. That's okay. C, Charlie. Which one? This one? Yeah, remove entirely if you cannot put it back again. C, Charlie. I can see right now the answers between C and D. Think about it clinically. That's what you gave the hint during session, right? If we are trying to extract tooth and break to porosity, we can stop extraction and then leave after, yes, putting detached bone. That's correct. E echo, okay. Now I see most of the answer D delta, which I'm very happy with this, right? Think, guys, about it clinically. Every one of you guys, please close your eyes and imagine you are in the clinic. Guys, who's this? The happy person? Guys, who's this, guys? Dentist. Happy person, dentist. I agree. And the guys, who's this? The lying down and not happy because he's gonna pay money and one of those will be extracted. Will be the patient. Right now, you broke this tuberosity. Now, what you need to do? Stabilize it? I agree. That's what we mentioned. The plus stitch, right? You're going to stitch the mucosa? I agree. But now, ask yourself a question. The question asks about the keyword, the next step. The keyword is, what is the most appropriate next step? Now, do you think you need to do something before stabilization and stitch or not? Because now, have we changed our extraction from non-surgical to surgical aseptic or not? When you are now going to deal with bone invisively and gums, do you think you're still non-surgical or surgical right now? After you broke the bone, the tuberosity, and you're gonna give stitch, now is it surgical or non-surgical? Very good. So it is, we need a septic technique, right? Now it is surgical. So which one you gotta do first? Stitch first or to apply the aseptic surgical technique first? Which one you gotta do first? Are you going to do stitch after a surgical, after aseptic, or before aseptic? So aseptic technique first, right? And then, okay, guys, that's a very nice question from Dr. Go Gulam Reza. Sorry for this, Gulam Reza. He's asking, what if some sharpness? Definitely you need to smooth it. But the question doesn't mention about it, so we don't assume. The word if means there's assumption here. We only answer the question based on the information provided only. There is nothing in the question has mentioned there is any sharp bone, because if you assume something, we can assume lots of other things. Okay, not just on sharp bone. So, aseptic technique, right? Okay. So guys, what's the right answer right now? D delta. If you really want to ask which stitch is going to be the best, I may go with Vicryl, right, which is B Bravo. Guys, there is Bido bites about. Guys, please, Dr. Guys, do you guys have Bido bites for, we give you Bido bites for sutures, right? Yes, yes, yes. Okay, very good. Yes. Very good. Okay. Please, we'll find the answer there. What is, guys, the best stitch has been mentioned in there? And the beetle bite? The one we most commonly use it in the clinic? Vicryl is the best, right? Yes, that's what we mentioned there. I'm very happy to hear about this. Okay, guys, that is great. Vicryl, very good. Guys, stitching, it's very easy topic. Just one page. One page is enough. Last time before the exam, just only one page. I gave it to them, and then it was like somehow it was fine. So please, guys, don't just complicate. I'm not saying complicated. Just guys try to think, try to get things easy. Just only read one page, and that's it. So guys, the answer was D delta. Now, 3 days after the extraction, the patient presents with severe persistent pain and exposed bone and the socket. Guys, what do you think the answer here? Is it A, B, C, or D and E? A, C, A alpha, A alpha, A alpha. D delta, doctor. Doctor, D delta was the last question. B Bravo, C Charlie, C A, B C. Seems like most of you gone with A or B or C, right? Guys, it's a big surprise. Should I surprise you? Are you waiting, guys, was a big surprise? Yes? Okay. A alpha. The lesion caused by a loss or failure of the blood clot in the socket. Is this correct information or not? A alpha, is it, this is dry socket, look. We mentioned the keyword. It is dry socket. It is alvarstitis. Now, do you think A alpha is the primary reason, the primary cause for alvarstitis or not, for dry socket or not? Yes. Thank you, Dr. Bavik. Please, guys, everyone likes Dr. Bavik comments. Thank you, Dr. Camila. Already explained. I love this. You got the point from now. Now you read the question properly. And that's why always, please, guys, read the question properly. So now, you know what? That is a primary reason why dry socket has happened. As you see right now, let's keep reading the question. You are in the clinic. Close your eyes. Imagine you are in the clinic. You have explained what guys, what was the patient name? Duna, maybe? Duna. You said Duna. Look at this. You explained the primary cause. You already explained. Past tense. English, guys. That was in the past. You have explained. No, this is perfect. Past perfect, right? Yep. You have explained, like means like now. You just now have explained the primary cause and the reason. So what is the primary cause? Duna, do you know how this has happened, Duna? There was a failure for the blood clot to form, Duna. Did I already mention A to the patient or not? Have I mentioned A option to the patient or not? Yes, great. That's why I always say, right? That's why I always say, right? That's read the question. Information in TG, information in ODL, information in ADA guidelines and ADA journals. Read the questions. Clinically based questions, guys. You must think this way. Now, you already have explained. You explained this one, right? And then she said, what else? Duna asked you, doctor, what else I should know about this condition? Like add more information apart from A. So guys, now, can you give me the two most important information about dry socket? One primary, one secondary. I need the most two important information about dry socket. What is the primary? What is the secondary? Lysis is primary. Lysis will result in what? Infection? Autoimmune disease? Okay, please guys, everyone open TG right now and check what is the definition of dry socket. Please guys, every one of you, open TG right now and see what is the definition of dry socket. You will find a definition something similar to this, right? It is painful, localized inflammation of or osteitis, either way, because osteitis means inflammation, right? Caused by, mainly caused by early loss of blood clot. So now, is it localized inflammation or not? Is it infection or inflammation? Guys, can you confirm this from there? Thank you. Thank you, Dr. Muhammad. That's the one. A localized painful. I love this. Ah, wow. Dr. Leish got it as well. Localized painful osteitis following premature lysis of clot. So now, is it inflammation or not? Why inflammation is important for me? Because I need to understand we need to treat the inflammation today and we shouldn't prescribe antibiotics. Dr. Taslim, did you get it right now? Option A is correct, but the scenario mentioned for option A, you already mentioned it. Clear now, guys? Did you get it? Again, I will explain this again. Do you agree that option A is the primary cause or the primary lesion, the primary reason for dry socket or not? Yes, it's a primary reason. Now, do you think the primary reason have been explained to the patient or not? Yes. Do you think B Bravo is a reason? What you have explained only causes or reasons plus management. Do you think B Bravo causes? Do you think B Bravo management or a part of pathophysiology? What do you think? We always, Dr. Walija, say, right? We always say, don't change your answer. It's a part of pathophysiology. Option B, not a primary cause. Option B, it's not a management. That's okay, Dr. Talshini. That's why we are here right now. right? I will explain about smoking soon. Okay, now, yes, smoker as well. Guys, a smoker is a risk factor or not? Can be a cause or not? So if you already going to include smoking, it will not be the best because two reasons. One, it's a cause. You already explained the cause. Two, tell me where about the scenario has been mentioned that the patient smoked immediately after extraction. Okay, smoking is the main risk factor, right? To make the smoking as the main risk factor, what the patient should do? Tell me now. To make option C correct, do you think every smoker ends up with dry socket? Or only it will be a risk factor if they do something? So yes, thank you. For example, Dr. Nandini, patient should have smoked after the procedure. Very good, Dr. Walija. Smoker after extraction. Now, smoke after extraction. Do you think right now the patient, any information that the patient smoked after extraction? Can you now tell C is correct? Or C to be correct, I should have added information here that patient smoked, right, immediately after extraction or in the same night. Now, option C can be correct. However, this is will exclude it again. Is that clear, guys, so far? Now, what do you think? Option D doesn't heal spontaneously. No, it does heal spontaneously. Option D is wrong because it does heal spontaneously. It does heal spontaneously in 2 weeks, but it's too sore. Okay, now, what do you think the right answer now, guys? That's very good, Dr. Simran. I'm very happy you got it. B, bravo is the right answer, right? Yes, if the Dr. Sal B, you are correct only if they smoke within 48 to 72 hours. But if they can be smoker and they can stop smoking. That's right, Dr. Muhammad. I agree in this. Even though we already explained about the causes. And this is one of the causes. Guys, is it a big surprise for you right now? That's why I say in always, please, guys, information from the book is just like basics. When you read the question, must be critical thinking behind it. You must apply this critical thinking. Yes, Dr. Simran, but they are not similar. One is cause, the other one is definition, is a part of it, post physiology. That's okay. That's okay. You now learn it now. So now it's B bravo. We all agree on it right now. Why cleaning Donna's dry socket? You have 3 cups. I'm not, guys, I'm not quite sure who really has done this question right. The one has done this question right. I may give you a gift if I meet you personally, okay? Because I don't want to promise something which I'm not sure about it. If you did this question correct, right? By the way, guys, this is rare. This rare scenario that has happened to me before. I got this question exactly this way. Okay? Yes, that's a rare scenario. Why cleaning Donna's dry socket? You have 3 cups on the tray. One with mouth rinse. That's number 1. The second one with saline. and one is empty. There's a third one. None of the cups are labeled. You haven't labeled anything. Sarah, which is 7-year-old daughter, points to the two filled cups, right? With clear content and asks, Doctor, what in these cups? So what is the most appropriate response in this way? E echo, very good. A alpha, very good. E to child, very good. Yes, Dr. Nandini. Critical thinking. That's, guys, what you expect from the exam, because you face clinical scenarios. They think is actually accepted. D delta. Now, E echo. Okay. Now, let's think about this. Do you think, is it really water? Who, guys, agrees? Who does agree with water? I have two cups, right? One here. Looks like a tooth. Anyway. One here as well. Two cups. One with water and the other one with mouth rinse. Sorry, with saline or water? With saline. Right? And the other one with mouth rinse. No? Cups with clear content is C, saline? Okay. Very good. Thank you very much for this. If you say water, they may drink it. Am I right? If you say water, if you leave the clinic, they may drink it. And they drink mouth rinse. Am I right? Dr. Arshnur mentioned D. So it's not water. Are you safe dense now, guys, when you say water? Nope. So water is not empty. She referred to two cups filled. So as long as filled cups, it cannot be empty. So empty is correct. So A and B actually wrong. Celine. If you said C, Charlie, saline or saline, right? In this case, she actually pointed to filled cups, means you are a liar. You lie at her. You're not honest, because one of them is saline or saline and the other one was mouth rinse. So that's definitely wrong. So now we are between D delta and E echo. For a baby, which one more safer? Which one will be more understandable? As a content, we talk about the content itself. Regard the nature of this content. D delta liquid, it's liquid. No identification. Why? Because look at this keyword. Not labeled. So as long as, now I'm telling the patient this way, I'm telling the child, as long as you don't know what inside this cups, only considered as liquid until you get the label written down and the information to it, then you can identify it. So never touch any cups filled with any liquid, because that can be anything. It can be medical content, it can be fluoride mouth rinse, it could be a saline, it could be water, it can be anything. It can be sodium hypochlorite. So don't touch these cups because they just liquid. This is the idea behind all of this. Unless they are labeled, now if they labeled as medical content, now it's medical content. Now, if guys didn't get this question again, I will explain to you. Let's say we all out from the room. And after I tell the patient, or the child, the baby, it's a water, or saline, or medical content, she may think she can use them for any reason because you identify them. But when you say liquid, I believe they will not touch them. Right? Who's getting gift? I'm not sure who has done this. Okay, guys, so the idea behind this is, Dr. Didam said yes for us. Did you say D? I haven't seen anyone say D, but I can give you gift. That's okay. I only guys say D after you did. Okay, Dr. Alvina. So you're gonna get it then, Dr. Leia. Okay, when I see you personally, guys, in the academy or anywhere, please, guys, let me know. I'm very proud of you guys. If it's labeled Dr. Rabia, if it's labeled as medical contents, right? Yes. So the safest way, as long as we don't know what's inside for a kid, we cannot identify anything unless it's been really labeled for them, because we just put ourselves in the child position. We explained already this question. What analgesic is the most appropriate for her condition? This patient actually should have very severe type of pain. This patient with dry socket, the patient comes back to the clinic crying a lot. So what do you think is the right answer here? Do you think paracetamol only will be enough for moderate type of pain? Look, if your answer is oxycodone, if your answer is paracetamol only, not enough, because pain is really moderate to severe. If your answer is ibuprofen, not good, because the patient has gastric bleeding, wrong. If your answer is paracetamol and codeine, we don't use codeine anymore. And by the way, do you know oxycodone as well? Not the first choice in these cases, because opioids, not the first choice in dry sockets. Do you know this? So codeine, we don't use them in Australia for dental analgesic anymore. GP, they still use some of it, but not us. The answer is D delta, siloxy, because it's gut friendly, and paracetamol because it's moderate type of pain. Niacid is always the best in this case. Let's guys check your answer. D delta, right? But still, Dr. Maheen, if you go in, yep, but still, right? If you go in to see the situation right now, patient pain, no one of them can work except D delta. Okay, yes. This is the best out of these options. There's no one is better than D delta in here. Oh, next scenario. A 62-year-old Torres Strait Islander patient present with severe pain associated with tooth 16. Clinical and radiographic examination revealed that the tooth is badly decayed with a crumbled crown and is deemed non-restaurable. Now, a keyword here. Two keywords. Actually, so far, crumbled crown. Guys, what does it mean, crumbled crown? There's the first keyword. Number one. Easy to break, right? Very soft. Very easy, like a shell, like eggshell. If you go in, right, to hold it, so will not be enough, right? It will break. Okay, now, rheumatoid arthritis, osteoporosis, will start the bisphosphonate therapy shortly. Poorly controlled diabetes, clearance. Now, what is the best time, guys, to do extraction with this patient? Is it before bisphosphonate, before you start bisphosphonate, or after you start bisphosphonate, or at any time or within a year? I see most of the answers C, Charlie. Definitely. The answer is before starting the anti-resorptive therapy. Why? Because the risk will be low. Now the risk is Morange. Morange means inflammation, severe type of inflammation to the socket because of bisphosphonate. Patient will have very severe type of pain if you do extraction after the patient started bisphosphonate. Now, if the patient doesn't start bisphosphonate, in this case, do you think going to be any risk? No, that's easy. So the safest time, the best time is before the patient to start the risk from bisphosphonate. So answer is B, bravo. At any time during anti-resorptive therapy, that's wrong. Because let's say if this patient lasts for 4 years, they're going to be very high risk. No, that's very high risk. Immediately after the first dose of anti-resorptive therapy, why should you wait? It's better to be before. Only after 1 year? No. In this case, you need to wait. The last wait will be 1 week before the next dose. So we need to wait, not at any time, not only after. That's wrong. It can be before. Only if the patient develops symptom bronch. That is distractor. Answer C, Charlie. Now, based on the attached photograph, which shows a modification to the standard inferior AVA nerve block, how does this technique differ from the standard inferior nerve block? Very tricky question. Critical thinking again. Let's see the answer. A alpha? A alpha. I'm very proud of you guys. Should be easy question then. I'm very proud of you. Easy one. A alpha. Why A alpha? Let's explain this. The insertion point. Where about, guys? Okay, can you give me the name of this structure, guys? What's the name of this structure? It starts with trigo. Trigo, mandibular, raphe, right? This one. Trigomandibular raphe, right? Let me check your answer. Very good, trigomandibular raphe. I'm happy. Now, the normal insertion of the needle should be medial or lateral. The normal insertion should be medial or lateral to trigomandibular raphe. It should be lateral. But now, what is the relationship between the needle insertion and the trigomandibular raphe? It is medial. So the right thing should be lateral, as you see right now. The insertion should be here. The right insertion will be in this part. About this part. But it should be lateral, but now it's medial. So the insertion is wrong. I mean, like the insertion is different. The question asks about difference. So insertion right so far. Lower injection height. How far should be the injection height from the occlusal plane? 6 to 10 millimeter. Count this somewhere from here to there. This is about 6 to 10 millimeter. So now, what is the relationship between the insertion of the needle or the height of the needle to the original standard? It is lower injection height. It's now lower injection height. Means, right? This is correct. And reduced needle penetration. True. Because, guys, how far should be the needle inside the mucosa? Is it 1/3 or or 1/2 or 2/3 or all of the needle should be inside the mucosa? The answer should be, thank you, 2/3, right? Which is 2/3. Perfect. Now, do you think this is 2/3 of the needle? 2/3 of the needle, which is about 25 millimeter of the needle, because the needle normally 35. The long needle, so we use, guys, long needle for inferior Ava nerve block. How long it is? 35 millimeter. So in this case, we need to insert about 25 millimeter. So I need to insert, we're supposed to insert the needle until here. No, actually, maybe a little bit back. Let's say until this level. So now it is less or reduced needle penetration. So if your answer were A alpha, means you did a great job. B bravo needle angle. No, really, I think the angle is okay because normally we written the premolar. The angle should okay for me because we written the premolar here. Should be okay. And then higher injection, totally wrong. This one totally wrong because it should be reduced. Sorry, it should be lower, not higher. Greater needle penetration, wrong, because we explained should be reduced. The injection side located 6 millimeter above the occlusal plane for mandibular molars. This is very confusing, this option, because the question asked about differ from But this is actually doesn't differ from. This is actually the standard itself. So that's wrong now. The orientation, that's correct. Distance from the last molar, that's correct. Higher injection, no, it should be lower injection. So guys, now the right answer is very interesting, right, guys? I really feel happy when I'm doing this questions, guys. Now, which of the following forceps is most appropriate for extracting 1/6? Option A, option B, option C, option D. Option A, option B, option C, option D. Let me check. Very proud of you. D delta, very proud. That's okay, Dr. Walija. See, Charlie can be, but not the best in the situation. D delta, yes, C, Charlie can be, but not the best. See? Okay, Dr. Mariella. I think you may need to do something on the, I'm not sure why. Maybe something in the settings. Not sure. Okay, guys, maybe different things, okay? Yes, D delta because grossly decayed, right? What's the name, guys, of this forceps? What's the name, guys, of this forceps? Cow horn, right? The cow horn. Why do we use cow horn? What's the benefit to use cow horn? B and C? B is the traditional, the universal one. It may actually pinch on the crown and may break it. We use it with most of the cases, right? And they see the same things universal. There is no any difference except different angle. This one from different angle to this. It's just like to confuse the candidates. If you're 100% sure it's a badly broken tooth and easy crushed, as being mentioned in the scenario, it's a crumbled crown. So in this case, right away, you think about either A or D with cow horn forceps. We use them in badly decayed teeth, the crumbled teeth, the crumbled crown. This is for left-hand side, and this is the right-hand side. Because tooth 1/6 is hand right side, so D delta. We always, guys, see the peaks should be toward the cheek. This was really brainstorming. Yes, Dr. Arsenal. Okay? The peaks should be toward the cheek. Yes, guys, to not remember, to not forget it, sorry. The peak toward the cheek or peaks toward the cheeks, right? Yes. Yes. So that's why if I'm going to put the cheek here and the peak toward the cheek, That's mean left-hand side forceps. And then, because the patient face will be like this, right, in front of you. That's right cheek, that's the left cheek. So this one, the peak will be toward the left. But if you're going to apply the same concept for the lower forceps, it will be different. The peak will be toward the cheek, and the cheek right-hand side, because the cheek here will be left-hand side. So this is right-hand side forceps. So easily, it can be useful tooth number 16. So guys, what is the right answer here again? D delta, right? Great. Question 4. The patient's medical history revealed that the patient is psoriasis islanda with rheumatoid arthritis and poorly controlled diabetes. What is the most appropriate management for extraction? I mean, before extraction, you need to decide, right? You need to decide, should I prescribe prophylactic antibiotics? Should I prescribe therapeutic antibiotics? Should I prescribe both? One only of them? What is my choice here? So what do you think? Two options, easy, you can exclude them. BIDU technique, right? In BIDU technique, we all start with exclusion. Exclude this one, clindamycin. Why? Because patient doesn't have allergies to anything, right? And tetracycline, not good for anything, not good for prophylactic, not good for therapeutic. So D and C is gone. Now are between A, B, and C. This is a confusion here. I see most of you B, bravo, and some C, or only one so far C. A and C, yes, B, bravo, A and C. A. Now, option A, only prophylactic antibiotic. Do you think this patient can be, guys, it does mention the most appropriate. At any stage, if you are in doubt, contact GP. For example, if I have an option here to contact GP, what can be the best option? I would say contact GP. Right? To determine this, I may say if there is an option here for contact GP or consult GP. In this case, I may choose it, but it's not given. You need to decide on your own. You are a dentist still. You have read therapeutic guidelines. You have read Bidubite. You have read Australian Dental Journal. You have read Dr. Cameron book. You have read enough materials. So now you can decide on your own. Now, only prophylactic antibiotic. This patient is immunocompromised. Do you guys agree on this? Why? Because patient is poorly controlled diabetic patient. So if the patient is immunocompromised, should I prescribe prophylactic antibiotic? The answer is yes. Except diabetic patient. Why is this? Again, evidence-based. Evidence-based. They found with researches and studies that even poorly controlled diabetes, very interesting information, poorly controlled diabetes that can be, or most likely, is immunocompromised patient, however, given prophylactic antibiotics with this patient doesn't help that much and not needed. Guys, are you aware about this fact? Did you read it before? Let me check. Guys, are you aware about this? Yes, very good. I'm happy. Yes, very good. So now we don't need prophylactic antibiotic, page number 182. That's good then. So in this case, we don't need, right? Prophylactic antibiotic. What's this one? Dr. Muhammad, Dr. Loving the session, just the confusion for this question. If a patient who is poorly controlled diabetes present with severe pain and a grossly broken tooth require an extraction, but the question STEAM doesn't specify whether the pain is due to localized oncogenic infection or periapical abscess or irreversible, but should we assume that therapeutic antibiotics are... No. You must have proper diagnosis, Dr. Muhammad, okay? You must have proper diagnosis if it is infection or not, or a sprained oncogenic infection or localized. You cannot assume anything. Thank you. That's a great question. Okay? Yes. So in this case, guys, I believe we don't need for prophylactic antibiotics because only the medically compromised patients part coming only from poorly controlled. Now, do you think rheumatoid arthritis it's it is on is immunocompromised condition? Just it's on. Is it immunocompromised condition? Dr. Arouj, before extraction, you need to decide what sort of antibiotics you need to give before you extract, right? So that is your management. It can be prophylactic, and therapeutic, or it can be therapeutic only. That's what you decide before extraction, right? Yes. Guys, do you think that rheumatoid arthritis on is immunocompromised condition? No. The patient should be on corticosteroids. Do you think every single patient with rheumatoid arthritis on corticosteroids? The patient is native origin. Yes, if the patient this is Bidu bites, right? Sorry, this is Bidu, how we call it? Bidu math. Bidu math, right? If tourist rate Islanda plus rheumatic heart diseases. Now we can prescribe prophylactic antibiotics, but tourist rate Islanda without a risk factor of any heart diseases, he is normal patient. Okay, not every single patient, every single native Australian required antibiotics. Okay, yes. So now, guys, option A only not valid. So now, if option A not correct, and option C as well not be correct because we don't need any of prophylactic antibiotics. Which option now, guys, only left for us? Therapeutic antibiotic, option B, therapeutic antibiotic. Why? Because the patient is poorly controlled diabetes. Doctor, now, you mentioned for poorly controlled diabetes, no prophylactic antibiotic, yes. That's evidence-based. This is the research. That's what we go right now. Before 2014, we used to provide prophylactic antibiotics to poorly controlled diabetes. We now stopped it, not anymore. But we provide therapeutic. So to make it easy for you, poorly controlled diabetic patient, right? No surgical prophylactic antibiotics before the surgery, but yes for therapeutic antibiotics after the surgery for 7 days max. Guys, again, if you still have any confusion about this, you can go back to reading TG or any other source you can rely on it. What this? Yes, okay. Now, guys, the issue now is some of you guys got confused by the word before. Okay, what is the most appropriate management before extraction? Before extraction. What is the most appropriate management before extraction? The word about management. Tell me, guys, what we need to do before extraction. As a management, what do you need to do? Guys, what need guys to do, guys, before extraction? As a part of management? Can call it management something. You can call it treatment something. Please, guys, tell me. Thank you. Thank you, treatment plan. You plan, right? Very good. Thank you very much, Dr. Shilpa. Thank you, Dr. Nandini. You planned, right? As a part of the plan, what we need to do? To plan. As a part of what we need to do? To tell the patient, you exactly need to do, like, is it simple extraction? Is it going to be surgical extraction? Is it going to take 5 minutes? Is it going to take 1 hour? Because you need to talk to all the stuff to the patient before you do. Are you going to prescribe analgesic? Are you going to prescribe painkiller? And then the follow-up visits and all this stuff, right? So now, do you think prescription, you decide on it before extraction or after extraction? Normally, guys, in the treatment plan, what you need to do? You need to prepare for the case. So now you need to be ready what exactly you're going to do, right? So most properly, in this case, it's just only simple extraction. Painkiller if required and antibiotic if required. That's it. Okay, did you get now, Doctor? Dr. Arshnur? So before means you plan for it before you do extraction, okay? Dr. Zainab, because he's immunocompromised patient, because patient is bad, the patient is has poorly controlled diabetes, and because the patient is has poorly controlled diabetes, so he is immunocompromised, and if the patient is immunocompromised, we prescribe antibiotics, therapeutic antibiotics. Dr. Hamid, the same things, Dr. Hamid. The same answer, okay? Because the patient is poorly controlled diabetic patient. Poorly controlled diabetic patient means immunocompromised. And with immunocompromised, so in this case, right? Yeah. Dr. Adam, I have a confusion. In this case, why we are giving therapeutic antibiotics here? In this case, the question doesn't mention if the pain due to reverse bulb bites or localized oncogenic infection. Doctor, we don't provide antibiotics in this case because the diagnosis. We provide because two things. Let's write down these two things. One, extraction. Let's say surgery. Extraction, which is surgery, right? Let's say extraction. One, extraction. Extraction only, no therapeutic antibiotic. But extraction plus immunocompromised patient equal to equal to therapeutic antibiotics. And because the patient is poorly controlled, means he is immunocompromised. So it means now we need to provide antibiotic for this reason, not for the diagnosis itself, not for reverse bulb bites or anything. Guys, am I clear, guys, about this? March kids seems like they are March kids. They need really to be cool, right? They really need to be cool to understand all these concepts, right? No, Dr. Salbi. If you guys, do you guys know what is the page number in this part so that Dr. Salbi can read about it? Please, guys, everyone, please, guys, help Dr. Salbi. Okay, guys? Yes. Poorly controlled diabetes, yes, Dr. Mack, yes. Okay, guys, please, guys, if possible, just try to get the page number for therapeutic guidelines. And thank you. Please, guys, anyone has confusion, easily, you can listen to me in this lecture because I already explained like 3 times so far. And then Dr. Leo make it easy to everyone. In page number 195 in TG, 195 and 182, you can go there, guys, and please read this part again, okay? I will explain it one more time. Wrap up, please. To get it right, you need to read this part. 1, if extraction only, if extraction exo only, without any other medical condition, no prophylactic and no therapeutic antibiotics. Easy now, guys, so far? Good. But extraction plus immunocompromised condition, now we will need for therapeutic antibiotics after the extraction. But, and also plus prophylactic antibiotic before. But because the patient is immunocompromised because of poorly controlled diabetes, they found out that for poorly controlled diabetes, no need for prophylactic antibiotic, only therapeutic as immunocompromised. Otherwise, the body will not be able to fight against the infection because there is not enough immunity. That's why they said they need for therapeutic, but not prophylactic, right? Because poorly controlled diabetic patients, no need for prophylactic. I hope now clear, okay? So guys, the answer now should be B, bravo, right? Next question. What guys you think the right answer for these options? For this question, the patient has been on bisphosphonate anti-resorptive medicine medication for 5 months and is now interested in having dental implants. What's your suggestion? A, implant should be avoided. Really? Why? Implant can be considered safe with precautions. I love this option very much. Let me guys check your answer. B, bravo. I'm happy. Oh, Dr. Leo, I know you intentionally answered A because you don't want to answer B, right? I'm sure about this. Right? Otherwise, if you answer B, I will say, why you answer B? Okay. The answer, guys, is B, bravo. We mentioned this before. The problem with actually anti-resorptive medicine, does guys make the bone stronger or weaker? People with bisphosphonate, people with osteoporosis, let's take osteoporosis here. Right? Do you think they have soft bone or a strong bone? Like brittle bone or a strong bone? Which one of these? With osteoporosis, soft bone or strong? With osteoporosis, soft bone, brittle. Guys, with osteoporosis. You answered my last question about bisphosphonate, yes. So now, yes, it's soft, right? Osteoporosis soft. And the patient now start to take anti-resorptive. What does it mean, the word anti-resorptive? Anti means against, resorptive means to be reduced, to be lost. So now, the medicine will prevent the bone to be lost. The medicine itself, bisphosphonate. Do you think now bisphosphonate going to make the bone stronger and better quality, and the bone has better quantity as well because we'll reduce the resorption, or it's going to increase the resorption, make the bone weaker, make the bone less quality? Which one? Better quality, less resorption. Bisphosphonate will result in better quality, stronger, less resorption, or more resorption, weaker, and less quantity and the quality. Which one of these? Stronger, better quality. Bisphosphonate makes it stronger and better. That's what's called anti-resorptive. So in this case, because it's anti-resorptive, guys, better quality, do you think bisphosphonate it's good for implant or bad for implant? If the patient only has osteoporosis, do you think osteoporosis only with implant is better, or osteoporosis plus bisphosphonate with implant is better? Which one? Bisphosphonate without, sorry, osteoporosis without bisphosphonate is better for implant, or what we're looking at right now is the osseous right? Yes. Which one, guys, was osseous integration? Definitely with bisphosphonate better, right? Yes. So yes, it can be. It can be considered safe with precautions. What sort of precautions? We worried about meronge. We worried about meronge. So what sort to be? It should be atraumatic, for example, right? It shouldn't be atraumatic. And then you need to ensure that you're going to do it 1 week before the next dose, right? That is the best at any stage after you take the medicine for a long time. And then if you want to have drug holiday, you can check drug holiday with GP as well. It may help situation. But is it really contraindicated? Is it really obsolete contraindicated to give implant with this patient? Do you think, guys, is an obsolete contraindication? Have you heard before one time, if patient on bisphosphonate don't give implant, never give implant? No. So option A, it does mention this. Implant should be avoided. No, it's not avoided. B can be fine. The patient has high risk of implant failure. No. There may be high risk of meronge, but not implant failure, especially loading due to anti-resorptive. No, during loading means like the implant is very secured inside. You only decide on loading crown when the osseous integration is perfect. When you have perfect, think about it. If you have perfect osseous integration, in this case, you're only gonna load the crown. And then once you load the crown means you already passed the risk time. The risk time is a time of meronge. That is the risk time. It's recommended to use a strict aseptic technique to reduce the risk of meronge. It's recommended to use a strict aseptic technique to... Anyway, you need to use it. You need to use it, but it doesn't reduce meronge. Meronge, it's not an infection. Meronge is inflammation. You must use aseptic technique, but not to reduce meronge, because meronge, it's happening because traumatic technique and the medicine, but not because aseptic or not aseptic, aseptic or not aseptic. The size of implant should correspond to the alva bone. That's okay. That must be in every single case. This must be. But there is not something specific. Because the patient asks you, should I get implant or not? Yes, you can with precautions, but this is just general information. It does not answer the patient's inquiry. Easy, guys, based on the photo, what is the diagnosis of this condition? And the explanation. Look at this. Look at this information. Look at this. Move around. How many keywords? One, move around. Two, irregular, erythematous, depapulated, rimmed by white margin, right? And then spice food. The answer is geographic tongue. Easy? Let's move on. The rest oral candidiasis, I don't have anything to support oral candidiasis. All the risk factors, the description of the lesion is toward easy classical features of geographic tongue. That is very simple, direct, classical features of geographic tongue. You cannot mess it with any other condition. The patient asks doctor, what is the cause of this condition? What is the most appropriate response? They ask about the cause. Guys, again, I put you some distraction here to distract you. I made diabetes as distraction. I made metformin as a medicine as distraction. Smoking as distraction. Allergies to rubber as distraction. But we only know one way, right? The exact cause is unknown. That's the easy, simple information about it. Dr. Dandini, love the distraction, but you trained us well. I'm very happy, Dr. Nandini. I'm very happy to hear this. But we didn't get distracted. I'm very proud of you guys. Okay, this is going to be showing in the next question. The next question is really, really, really tricky question. I hope, guys, you answer it right as well. Okay, let's see this. Look this. But please, those next time you need to read. You need to do it. Okay, you need to read everything. Now, if you tell me what is the right answer here, I will be very, very, very happy. Oh my God, he got it. Oh my God, perfect, guys. How do you know it? Wow. Dr. D. Damish, how do you got, guys? Dr. Shashank, how do you get it? Dr. Tariq, how you get? Wow. Wow, guys, I only played with one word. I'm proud of you. The answer is E, echo. I only played with one word, two words actually. Thank you, Dr. Alwina. Yes, that's two things, painful and burning. Only, that's a two words, right? I played with. Yes, the word only as well can make it wrong, yes. Pain 6 weeks, that could be another keyword. But mainly, because it's painful. I'm proud of you guys. I thought it's hard. Wow. Because we understand normally in cases of geographic tongue, we just go with simple reassurance, just to reassure the patient. But because it's painful condition and the burning, it means it's not just geographic tongue. There's something hidden there. We need to find it out. That's why we need to seek for oil medicine. Now, If you want to make C option correct, what we need to change here and what we need to change in this option. Two things. Change this two word, replace this two word with something, and then remove one word from here. So guys, can you give me the word we should replace here? Give me only one word to replace these two words. We are well trained now. Just week left. I'm very proud to hear this. Yeah, normally, guys, patients feel something. I remove the word only, and the word is symptomatic. Sometimes the patient feels something with spicy food. Sensitive. Very good. That's a word. I like that word. Sensitivity. I like that word. Sensitive or sensitivity to spicy food. So now we need to do two things, right? One, to replace these two words. I love this, guys. I love you really. Like, you actually take care for all the blueprints, for small details. That's a spirit. I love this. Now, to make this, to make reassurance is the correct option, not E. I need to replace this with sensitivity, not pain, not burning. And then I go down there. See, guys, I'm teaching you how to do questions. Now you can do questions for yourself. Look, and then after this, I remove only. So now simple reassurance can be right. Otherwise, E echo is the best answer. So now it's E echo. I'm very proud of you. Next question. The patient requires root canal treatment on mandibular molar, given that he has positive history of allergies, rubber allergies, somehow to latex. You are planning obturation according to the ASCI recommendation. What is the right answer? This is very tricky question again. Very tricky. D delta, E echo, D delta, D delta, D delta, D delta. Let me check. What is D delta? Look, this is, I told you guys, this question or this type of question is completely out of the, like completely doesn't rely on anything except someone who just in this life to read books, like Dr. Dibali. Someone like Dr. Dipali, which I love. I will now give her big heart. Right? Let me just give big heart to Dr. Dipali. Oh, I gave it to Dr. Javier. That's okay. You, actually, Dr. Javiera, you deserve it too because you do a very good job. Dr. Dipali, because she born in the valley, and the valley festival. That's why her name is Dipali. Sorry, Dr. Dipali. Right? So I give you a big heart right now. How do you know about this, Dr. Dipali? Guys, this question needs someone doesn't do anything in the life, it just only accept reading. Okay, guys, please, guys, go back again. If you can read the ASCIA recommendation, right, in Australia, right, you will find that Gata Persia has reported this word is wrong. Remove this word. Now D delta is correct. Gata Persia has reported cross allergies to Rapa. Why? Because it's somehow being extracted, the Gata Persia, being made from the same trees, species, that's latex made from. Like, for example, animals. You know, animals, it can be dog, it can be cat, it can be donkey, right? So Gata Persia has been made from the material which is under latex material. Same species, same type, not exactly latex, but same type. That's why it has cross allergies, right, to rubber and latex. But you should ensure there is no overfilling with gutta percha, because the only issue we're worried about, when the gutta percha passes the roots, when the gutta percha passes the apex, and now become in direct contact with the mucosa down. Here is the issue. Apart from this, if it's just only inside the root, nothing gonna happen. I hope now this question is clear. Which one? I will go with the other one. Don't use gutta percha points. That's wrong. You can use gutta percha with precautions. Use gutta percha only with resin sealer. This is distractor. Anything. Don't use zinc side free eugenol as sealer because rubber allergies. That's not true. Free zinc side free eugenol is rubber, doesn't have anything to do with rubber allergies. Gutta percha has no reported. It actually has reported. So answer, guys, is E echo. Please, guys, take this name right now. Go and search for this topic for allergies. You may find in infection control, AD infection control guidelines, somehow mentioned indirectly. Because infection control guidelines takes from this organization, this body. ADA, infection control guidelines, they take information from this organization, this body in Australia. It is in, okay, very good. Dr. Rahman, have you seen it in the 9th edition? In infection control guidelines? I'm very happy. It's mentioned in, very good, I'm happy. Okay, guys, that's great then. It's mentioned there, guys. Dr. Nandini shared, guys, shared the article. You can read about it again. Thank you very much, guys, for this to help everyone. I'm proud of you. Now, the answer, guys, E echo. Look, this question, it's totally, as I told you, it does need only for one, does nothing to do in this life, except only reading books, like Dr. Dipali seems like. You use the product with latex, and the mid procedure, the patient develops wheeze urticaria and blood pressure 85 to 50. First action. Do you think the first action, okay, diagnose this condition first. We need a diagnosis for this condition first. What's the guy's diagnosis for this condition? Is it just urticaria, like mild type of hypersensitivity? Is it delayed type of hypersensitivity? Is it immediate type of hypersensitivity? Is it anaphylaxis shock? Which one of these? Anaphylaxis. Thank you very much, Dr. Leah. Anaphylaxis, yes, it is anaphylaxis. Yes, it is anaphylaxis. Right? Yes, it is anaphylaxis. Yes, anaphylaxis. How do you know it's anaphylaxis? Right? How do you know it's anaphylaxis? Because the blood pressure dropped a lot. Look at the blood pressure. Now with anaphylaxis, you will find the blood pressure drops a lot. Apart from this, you find patient has diarrhea. Apart from this, you will find the patient start to be pale, and then the patients may start to have tummy ache, tummy pain, all of these signs and symptoms of anaphylaxis shock. Definitely the depression and respiratory depression will not be able to breathe. Right? Yes. So guys, answer is, I see some people, they have different opinion. Dr. Hent said, Anaphylactic shock, adrenaline is very critical. Give first, then call 000. I agree to Dr. Hind. And then I have seen different things, which is call 000, right? I believe adrenaline first and then 000. Guys, what's your opinion, guys, about this? What is mentioned TG? Adrenaline first or 000 first? I go with adrenaline first because the patient is going to die if you don't give him adrenaline. His heart will stop. His heart will stop. His respiration will stop. You need to increase the cardiac properties very quickly. Why should you wait for 000? I agree to this, guys. See, Charlie, I agree with this. TG said 000. Okay, Dr. Muhammad. Can you please double check this for me, Dr. Muhammad, and everyone, please, guys. Dr. Maheen, can you please check the triple? Can we check? TG again for this, please, guys. Every one of you, tell me what's mentioned TG. Everyone, tell me TG page this has mentioned this. Okay, go to anaphylactic shock, please, guys. Adrenaline first TG. Okay. Intramuscular first TG. TG says intramuscular first, then 000. TG first adrenaline. Okay, most of you say TG adrenaline. Okay, there is also mention of 000. Chin 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 chin. It's also mentioned 000 before adrenaline on page 238. Page 238 called 000. First injection, then 000. 238, okay. Now we can check the 238. Adrenaline first TG. First, okay. 238 000. Adrenaline first 239. That's funny. So which one, guys, are gonna go? Both. Which one, guys, do you think is better? Do you think to give injection? Guys, in movies, what happens is you give injection first and then call 000, right? Clinically, guys, which one? We understand this. If the patient get real allergies, what you need to do is just stab him with adrenaline straight away. Yeah, you need to watch these movies then, right? No, actually, TG mentioned both, but clinically, I believe adrenaline is more important, guys, before 000 in this case, because the time you call 000, they will come back to you say, EpiPen, do you have EpiPen? Ah, yes, I did it already. Guys, what do you expect? What do you guys expect 000 will tell you? What do you think, guys? What do you think 000 will tell you? No, Articaria, we don't give adrenaline, guys. Articaria, we don't give adrenaline. Articaria, we give cortisone only. No, guys. Not Articaria only. Articaria, we don't. How come you give EpiPen intramuscular EpiPen for Articaria? No. Yes, this actually, this guy's anaphylactic shock. We talk about anaphylactic shock, okay? Now, guys, which page doesn't mention about anaphylactic shock? 239 or 238? Which one? Guys, which one, guys, is anaphylactic shock? 239 or 238? Okay, and 2-3, now we talk about this case is anaphylactic shock, right? So in anaphylactic shock, Which one first? 000 adrenaline? In 239, I'm checking now, guys, your answer as well to ensure we do the right thing, okay? In 239, which is anaphylactic shock, which one is first? Adrenaline first. Am I right? Oh, guys, now agree on adrenaline? Dr. Bishoy's, this is logical. 239 is logical. I now agree. Okay, I'm happy now I agree. Okay, guys, this case is, you see, I'm happy to discuss with you. We discuss together the right answer until we both agree on the right answer. Now, guys, do you agree with me? It's adrenaline now, everyone? No, Dr. Mahin? That's fine. Which one's the right answer, Dr. Mahin? Okay, Dr. Mahin, think about it now, okay? Forget TG to the there. Do you agree, Dr. Mahin? That's okay. 238. Go, okay, that's good, Dr. Mahin. That's fine. Now, think about this way. You still, Dr. Walij and Dr. Mahin. Yes, say hi, Dr. Mahin, right? Yes. Say hi, Dr. Mahin, please. Yeah, think about it. It's just easy thing. 238. Okay, hi, Dr. Mahin. Now, 238. Is it for anaphylactic shock? Guys, 238 is a management of anaphylactic shock. Look, anaphylactic shock is in table. Table has order. Table, it should be in order. I need the table. Table is the order. Which one, guys, in the table? I'm not quite sure. Look, for me, I'm talking about my clinical experience, about overall information since long time. I know if something happened, patient has anaphylactic, the first things ever I need to do, hold the needle EpiPen in my hand, and straight away stab him. That's what I know. And then call 000. Now, in the table, which one is mentioned for anaphylactic shock? Now, it says urticaria angioedema associated with hypotension and evidence of anaphylaxis. This matches the presentation of the case most. Yes, it is. Yeah, because this is now anaphylaxis. This means anaphylaxis now. Hypotension means anaphylaxis shock. Angioedema is anaphylaxis. Hypotension is anaphylaxis. Guys, in anaphylaxis in the books, which one? Okay. So how this can different than the table itself? What's in the table? How this is very good point, guys. This discussion is very good one. I really like it. Now on 239, do you think the patient with hypotension is anaphylaxis or not? Guys, if the patient has hypotension, is anaphylaxis. Okay, okay, now this case is hypotension. This case is hypotension. Evidence of anaphylaxis and existing anaphylaxis are two different case presentation. How? Okay, tell me. So what are you going to do here right now? Okay, Dr. Mahin, I believe, look, that's okay. I believe if the patient has urticaria, has angioedema, like flushing faces and all this stuff. Okay, can you please, Dr. Mahin, can you please give me the signs of urticaria? Sorry, the signs of anaphylaxis? Okay, guys, now can you give me, guys, this? with hypotension, management of anaphylaxis, stop treatment, remove allergen. Okay, guys, let's read this one, please, guys. Dr. Yatri, management of anaphylaxis, stop management, remove allergen, lie the patient flat, give, this is from TG, Dr. Yatri, give intramuscular adrenaline first, and then code 000. Yes, difficulty breathing, swallowing, throat wheezing. Right? Yes, and then there is no blood pressure, drops in blood pressure. Yes, okay. So Dr. Leah, she just only removed the hypotension. Dr. Mahin, she just only removed the hypotension, right? Guys, does anaphylaxis hypotension or not? I agree. It has bronchospasm, air obstruction, hypotension. It does not necessarily to have all the stuff in one go. Anyway, now, look, guys. This case, stop dental treatment, anaphylaxis, and evidence of anaphylaxis. For urticaria, okay, let's read this one as well. Let's read Dr. Walija as well. For urticaria or angioedema with associated hypotension and evidence of anaphylaxis, student treatment, remove or stop administration code 000, give intramuscular. So, okay, guys, let's say right now, both of them correct, okay? Let's say both of you correct right now, okay? If it happens, but please, guys, think about it. If TG has mentioned both of them, right? And I love this discussion because now it's brainstorming. TG has mentioned both. If in your clinic, and this is one of your family member, what will you do? Look, patient, the blood pressure is very low. Now, if you call 000, if we call 000, it may take some time for the heart to work. But if you give adrenaline, because guys, what is the effect of adrenaline? What is, guys, the effect of adrenaline? It will raise the blood pressure. Now, it's your choice. Do you want to waste some time calling 000, or you want to save the person in front of you with EpiPen? Okay, think about it. What these people gonna tell you to do? What the 000 gonna tell you to do? They will ask you to give adrenaline. Am I clear, guys, about this? Yes, on the phone they can call you. Now, let's say the two are right from TG. I agree, guys, to you. Okay, both are right. Both things are right. Right? Now, if you are in the clinic for yourself, what you going to do? And by the way, that's a type of question, guys. EDC want you to think clinically. I will say, okay, what is the best management? Okay, some allergic reaction are self-limiting, and we don't know if it is anaphylaxis. Still, the obvious signs have set in. My brother has an allergic reaction, and we were advised to not give adrenaline unless obvious symptoms. Okay, what, Dr. Mahin, did your brother got the blood pressure down that way? Because believe me, if paramedics have seen the blood pressure that down, and they didn't ask you to give EpiPen, that will be a fatal mistake, because they can drop for a second and heart will stop. What do you think? You already have enough evidence. Okay, are you going to wait for your brother to get the blood pressure lower than this and blood stops? I definitely agree on this. I agree. If it's just only a little bit of like rashes, maybe puffy face, a little bit of vesicles here and there, I agree. But what about the blood pressure? Guys, what do you think your opinion? Guys, which one's first? I go with, I respect to both. Okay, why only? Okay, we only follow the instructions since we're not at that time. But do you think about blood pressure? So guys, now what do you think, guys, overall? I respect both opinion. I respect if you're gonna start with 000 first. I respect if you're going to do adrenaline first. Clinically based, as patient is in danger, the blood pressure has dropped badly. I need to do something now, right? Because I have an evidence of blood pressure. AB first. Look, I will go with this one because the blood pressure. You know what? If there is no low blood pressure, that much low, I wouldn't give epinephrine, and then I can call 000. Anyway, let's say, hopefully, you will not get the two option exam, okay? Dr. Maheen, because I know you are into this question by heart. And by the way, I agree with you. 000 can help. Both of them can be fine. Okay, so guys, if this is happening in exam, it's up to you. If you want to call 000 first, call 000. If you want to give, if you give this, if you want to give adrenaline intramuscular, give it two. Right in this condition, based on understand the question. Okay. Yep. Dr. Shavin asked to move on. Guys, would you like to move on or more discussion this question? Please, guys, let me know. Is it clear? Hopefully the exam doesn't give. I look, Dr. Bain, I wish so too. This question will not come. Let's see. Okay, guys, let's keep going then. Okay, as long as you're happy, you know what? I will mark this one and I will mark this one too. Like this and this. And now let's see what's gonna happen at the end. That's it. But at the end, I made I am. Anyway, what is the most likely reason for the child fluorosis, guys? A, B, C, D, and E. Which one? Easy one, right? A, right? Yes, ingestion. Excessive ingestion fluoride. If you said use of other toothpaste at age 5, that can be fine as long as the patient doesn't ingest it. So whatever the patient gonna use, to get fluorosis, the patient must ingest excessive amount of fluoride. Anywhere, if the patient use B or E, any one of these, B or E, to get fluorosis, they must ingest it. What if they take toothpaste and never ingest it, never getting fluorosis? What if you get high concentration? Can you please, guys, give me an example of high concentration of topical fluoride? If your answer is, please, guys, admit all the candidates. If your answer is vanish, fluoride vanish, I'm happy. Dr. Leo is back with B. Oh my God, Dr. Leo. No B anymore, Dr. Leo, okay? Okay. Yes, so now, definitely, E is not correct. B is not correct because I must have excessive ingestion of fluoride. Drinking tank water, it doesn't make that much of fluorosis because tank water has no fluoride. And the person is just distracted. So now answer, guys, A alpha. You plan to extract tooth number 46. The child is overweight. Sorry, guys, I'm admitting that. Child is overweight. Which one of you this guy's going to follow? The ideal body weight. The ideal, which is the body weight and the age together. The body weight and the age together. See, Charlie, ideal, very good. Do you know that there's some candidates answered e-echo when I looked at the mock exam? Your guys' answers, I found some candidates. By the way, I believe they are not our candidates, guys, okay? They said the height and the width of the patient body. How come can be the width of the patient body is a measure in this case? When I looked at their answer was, really? Okay. Hopefully they're not going to exam soon. I hope so. Anyway, I checked the names. They're not our candidates. Even contact the academy. They are our candidates. Said no. Okay, I'm happy. Okay, guys. So the answer is C, Charlie. Yes, they said what? Believe me, they chosen width. I can give you a screenshot. So the answer, guys, C, Charlie, right? Okay. Which local anesthetic is most appropriate for this patient taking monoamino oxidase inhibitor? In monoamino oxidase inhibitor is antidepressant. Antidepressant. And then the problem with monoamino oxidase inhibitor doesn't let the adrenaline, which is vasoconstrictor, to break down in a proper speed. So what can happen to adrenaline is the adrenaline will break down the absorption, which is breaking down inside the body very slowly. So the effect of adrenaline will be very high for longer time. That's why we do like adrenaline with monoamino oxidase inhibitor, which is antidepressant. And because we do like vasoconstrictor, which is adrenaline, so any option with adrenaline should be fly away. So this option will fly away, this option will fly away, this option will fly away, and this option will fly away. And this is easy as Bido technique. Options with similar information mostly will exclude each others. So A excluded B, C excluded E. So the right answer right now is D delta, prelucaine 3% with philipressine, because philipressine can be fine in this case. Next question, guys. After reduction, you want to prevent over eruption of the opposing molar while waiting for eruption of tooth 46. So that's the case right now. The case similar to this. Give me, guys, one. Yeah, that's the case. Look, I'm not very good in drawing, but the case is you have incisor, you have canine, you have premolar. How old is the patient? 11 years? Maybe premolar can be fine. At 11 years, I think premolar will be erupted. Premolar, or at least there is no deciduous teeth at 11 for now. And then you need to extract this tooth. But 7 is here, down there still. And then you are worried from 6 to over erupted and the premolar here. So now you need to prevent 6 to over to down there after extract 6. Now extract this one. Now it's space. You are worried to 6 to over erupted in this area. So what is, guys, the best advice? Sorry, the best advice in this? Full-time space maintainer wear, but which one? And the patient has condition here. The condition is the baby mentioned he cannot wear the appliances every time. They only happy to wear it at night. So now the key word is at night. So now I need something to be removable so they can wear it only at night. So now I need removable removable appliance. Full-time space maintainer, that's wrong, because you only need at night, and that can be applicable. That's okay. We can do this at night. Fabricate a band and loop space maintainer. Band and loop is fixed. Will not be at night. Provide distal show space. That's fixed. Will not be at night. And also, I don't think that's the best way in this condition anyway. Extract the contralateral mandibular molar. This is distraction. Not correct at all. So the only one left, guys, which option now the only one left? B, bravo. I hope Dr. Leo now mention B, bravo. Finally, B, I'm very happy. B, very proud of you guys. B, why? Because it's removable. And that is the best whole A, right? The whole A is the best in this case. And is it passive or active? Do you think, is it a modified whole A? Is it passive? Sorry, this whole A appliance, is it passive or active? It is passive. Doesn't put any force or any teeth. It just will work as a space maintainer, and that's it. Because the next question will be different. The next question, his mother asked, what is the most conservative treatment for a single tooth crossbite? Now, crossbite, if you have a patient with crossbite, do you need active appliance or passive appliance to push the tooth back again? Especially if you have vertical anterior vertical space, enough anterior vertical space, like the occlusal space. A, right? How does, because once you put it, doctor, it will replace the tooth, doctor. It will replace its space maintainer. So it will replace 6 after extraction, and then 4, 6, and then 1, 6 will not erupt in the space because we're going to close the space back again. Right, yes. So now, guys, modified whole layers appliance is now active. The word modified means you're going to add some components into the whole layer appliance to push this tooth back again, and then it will work out nicely, or single tooth crossbite. So now the answer is modified whole layer appliance. Headgear is too much. Headgear not for this case. Headgear to not change one single tooth. This is one single tooth only. Headgear, it's actually should be placed for extensive, extreme cases for bone growth. It's not for this only one single tooth movement. Conventional, no. Conventional, no. Without modification is correct. Is incorrect. You need something with modification to be active, not passive. Bite resin with composed restoration. Do you know sometimes bite resin? Do you know sometimes bite resin can be enough, but with composed restoration for a child 11-year-old, that's really too much. I don't think that will be acceptable for 11-year-old. Guys, in this case, if you want to raise the bite, what's the name of this appliance? This appliance. We discussed it before many times, this appliance. What's the name of the appliance that it can help in this situation? It's placed anteriorly, and it should be inclined to give a proper deflection for the teeth. And then once you raise a bite, the tooth in the back, which is cross bite, which is more lingual, it will become more buccal back again, especially with deflection. It's called inclined something. Dial appliance, yes, it has anterior bite plane. Yes, the inclined anterior bite plane. The inclined. Dial is a part of, it can be attached to dial appliance. It can, very good. Thank you very much, Dr. Salbi. Dial appliance, anterior inclined plane. Anterior inclined plane can be easily attached to dial appliance to work all together as one go. Yes. So the answer now, modified whole ways appliance. You are working community dental health clinic. Which of the following code can be assigned to this patient? Guys, Salness and Liu, as long as the patient has has accumulation of soft deposits, right? And there is gingival pockets, it will take us to D delta, right? Number 3. Guys, this theory, it's very easy to know about, just theory. Just a small table, read the small table. You will be able to say exactly it's number 3. Which one of these guys, the best average for fluoride? Is 1.5 or 1.5, 2.5 or 0.8, 1.2 or less than 1.0.8? The answer should be C, Charlie. 0.8 in humidity towns like Queensland, because it's very hot, like Cairns, like Northern Territories. All these places, it's very, the weather there is tropical weather, very hot weather, so patient will drink more water. That's why we need less fluoride. In areas like Hobart, right? Like Tasmania, it's too cold. So in this case, patient will drink less water. That's why we need 1.2. In Sydney, I think we use 1 because we have good weather, not like Melbourne. Guys, I'm just kidding. That's why we use normally 1 in Melbourne. Sorry, in Sydney. Now, what must be the first step in community management of this village? Look, seems like the fluoride is very high. Fluoride was really very high. I believe it was about 2. Oh, no, I don't want to go back. Cancel. Right, I think go previous from here. The fluoride was 2 ppm. 2 ppm. Part per million. In this case, it's really high. What must be first step in community management of this village? Start fluoride toothpaste program. It already has enough fluoride. Initiate defluoridation of drinking water. Distribute calcium tablets. Educate on toothbrushing. No, actually, because it's very high, we need to do this. Not us, but the government, I mean. Right? Not us. Definitely, that's the government. I see most of you answer B, bravo. I'm very proud of this. I'm very happy. Which of the following statements is true? Fluoridation has the greatest effect in the lower social groups and appropriate to remove antisocial class differences in dental care experiences. The first study, fluoridated water supply in Australia is Melbourne. No, I think it's Hobart, not Melbourne. And then Sydney. That was maybe 1963. In 1963, like 1 year before this guy, I think Hobart was the first city in Australia. They got this. And then maybe 1 year later, 2 years later was Sydney. And then after maybe few years, like 5, 6 years, was Melbourne. And then Perth in West Australia. That's wrong. Fluoride has been found to have no beneficial effect. No, that's correct. Incorrect. Fluoride is being used regularly and effectively in trainers to bureau. That says anything. Answer A, Alf. Let me check, guys, your answer. A, I'm very happy. Yes, Hobart in Tasmania, you're right. Which fluoride delivery is most cost effective for the community? Any community, guys, which fluoride delivery is most cost effective? See, Charlie? Yes? Okay, guys. See, Charlie, definitely correct. Now, if C Charlie not the right answer, what could be the best next answer here? Let's say C Charlie not existing. What can be the best next answer after C? By the way, guys, we'll have our session tomorrow, which is Wednesday, the private session. Tomorrow, Wednesday, at 7 p.m. Sydney time. Okay? And for our champions, for March candidates who start with us, guys, you can come. Sorry, you will attend the session with us because you have free, not free. I mean, it's bonus to you to attend these sessions these days. Only write down my notes. We have a schedule plan for you if you really want to go through it. But at this stage, you shouldn't stress yourself up at all. Just only enjoy what we do. See the stress of our September Champions Gold exam. Okay? That's it. And take notes as much as you can from our sessions. And listen to this, our enjoyable discussion always, right? About what can be or cannot be. By this way, you never ever forget our discussion. So now, guys, let me check your answer. But don't say bye-bye, okay? Stress. Next is E. Bottled water. E. Why, guys, I believe D is much better than E. Why I believe D, regular vanish application, will be before E and then E. If you ask me my opinion, C and D and E. C first, D second, E third. Okay, guys, how was the mock overall after discussion, guys? That's okay. If you find it as next space, that's okay. Okay, that's okay then. For me, come and see dentist every 6 months to only charge $40 for vanish, or maybe even less than this, will be much better than to buy every day bottled water with fluoride. It's not really very expensive, still bottled water. Not really very expensive, but if you compare both, I would say vanish is much better. Eye opener. I'm very happy, guys, with this. The best, too good, I'm happy. Eye opener, but too many silly mistakes. That's okay, Dr. Benny. Look, we are here to learn, not to score the highest, just to learn. And then have discussion. For example, the question for allergies, for anaphylaxis shock, we will not ever forget this information because we have enough discussion about it. And in the exam, I think the options will be more straightforward. It can be either 000 only, or can be maybe adrenaline only, not two together. Okay. It was tricky, but was too good. Mock was easy. I'm very happy to hear this, doctor. Doctor, you remind me of my anatomy professor named Dr. Mahmoud. Speaks exactly like you. I hope you like him, Dr. Kirti. And then we all guys should say hi to Dr. Mahmoud. Okay? I'm happy that's I remind you of him, but I hope he was good to you. Was eye opener? That's great then. Super duper? Okay. Super duper, that's a good then. Great exercise before exam. I'm very happy to hear this. Love it, doctor. So much critical thinking. Thank you. No problem, Dr. Nandini. What's the next best option C? I would say vanish. For us as dentists, I think vanish and then bottled water. But anyway, they both very important. The only mock I have passed since June. That is great, but you answered very hard question, by the way, Dr. Dipali. I'm very proud of you. Love it. I'm very happy, guys. You loved it. First and sixth, always the first choice, always the right one. Please don't change. I agree with Dr. Sabah. Dr. Muhammad, it was exciting mock, doctor. I'm very happy to hear this, Dr. Muhammad. And by the way, you did very good. I can see your answer. The follow up on your answer did very good. Thank you, Dr. It was very good. Thank you, Dr. Mariam. Learn a lot today. I'm very happy, guys, to hear this. Financial application required then supervision. Yes. Yes. I mean, like if you have an option for dentist, yes, I agree it will be good. Thank you, doctor, for mock. Thank you very much. Dr. Arshin or Dr. Bid, you are great, great. Thank you. Please see Messenger. Okay, I will. You know what, doctor? I every day I try to read as much as I can from my Messenger. But yes, I will look at it because I have long list of messages in my Messenger. I really need to go through all of them. But I will do, Dr. Arshinor. Especially this time, I got lots of messages. One more, please, Dr. Bid. Okay, Dr. Snea. I think we can do this. Learned a lot. Thank you, Dr. Jalish. Learned critical thinking improving. Thank you so much. Thank you, Dr. Reda. Dr. Taljit, thank you, Dr. Bidu. You're wonderful. Dr. Taljit, you are wonderful. Thank you. Thank you, guys. Thank you, Dr. Dipali, very much. Thank you. It's my pleasure. Dr. Mus, Doctor, what is the passing percentage? In this mock, I would say, believe me, 50% pass percentage. However, in ADC exam, we all must score the best. We should be the best ever. Our aim in ADC exam is 100%, okay? Dr. Taslim, thank you, Dr. Bidu. Love the mock. Thank you, Dr. Taslim, very much. In poorly controlled diabetes, immunocompromised, why therapeutic antibiotic without spreading infection? Where in TG? Dr. Hamid, there is an, I think it's the first page is in anaphylactic, the second page of prophylactic antibiotics. There is a topic in TG, it's called prophylactic antibiotic chapter. I think the second page, the first, maybe second or third. You will find, say, something like immunocompromised patients required prophylactic antibiotics, but poorly controlled diabetes, we have found there is not enough studies and stuff has shown the importance to take prophylactic with this patient, so it's not required. Something like this. Please, guys, if you can help with the exact page, please, guys, you can help him. Yes, Dr. Anopreya, it's contraindicated, but still that's the best option. In this case, what you can do is you can contact GP in this case. Yes, yeah, but because there's no any better option than this. I agree in this, Dr. Anopreya. NSAIDs and corticosteroid both together not working together. I agree in this, but that was the best, right? And if you are in doubt, always contact GP. Thank you, Dr. Bido. There is a precautions, not exactly not, but there is precaution. You can only maybe prescribe it for 1 day or 2 days, but not for long time. If you read more guidelines about this part, you will find this way. For corticosteroid and NSAIDs together. Session was really great. Thank you very much, Dr. Simran. Please go through soon. I will do, Dr. Arsenal. Doctor, in the ninth edition, get the pressure is not considered a problem in latex allergy patient. Okay, please go back again because the articles being made in 2024, the guidelines, please the one I'm the in the ACCIC, please if you can go there, the A1, then go there and then try to find it. It is made in 2024. That's the latest one. Go please and check it there and you will find it, okay? And please come back to us. We can discuss this again, Dr. Kanika. No problem, Dr. Arshinor. Thank you, everyone of you guys. Yes, more mock. Yes, please. So it's great and awesome to practice our clinical thinking. That's thank you very much. Thank you very much, Dr. Luciano. Thank you very much. Thank you, Dr. Sneha. Thank you, Dr. Didi Tamish. Thank you very much. Thank you, Dr. Tolika. I really appreciate this. It was great mock. Really enjoyed it. Thank you very much. I did enjoy the mock only because you are here, guys. Dr. Alexandra, thank you so much, though. Thank you, Dr. Alexandra. Wow, it means I passed. Yes, Dr. Musa, yes. Dr. Alan, thank you, Dr. Bido, for this mock. We'll read questions more properly now. I love to hear this. That is the main benefits and the main goal in this mocks. Not to score high, but to be more into eye opener and learn more before you go to exam. In Torres Strait Islander patient with rheumatic arthritis, no prophylactic unless a patient was on the patient on corticosteroid. If the patient on corticosteroid, therapeutic corticosteroid, now we may prescribe prophylactic antibiotics. So can you please provide? I think in Bido Bites, Dr. Dr. Reddy, I think it's Bido Bites. Okay, Dr. Bido, thank you. You can go with. Yes, yes, please, Dr. Anopray. Thank you very much, Dr. Anopray. I would say 50, 60% in this exam. Thank you, Dr. Mahin, very much. And by the way, it was very nice point, Dr. Mahin, the one you discussed. It made us to discuss more about it. And that's actually made us all understand better about this one. And believe me, by myself, I will never forget about this point all my life then. One more mokeke, Dr. Mehek. Thank you, Dr. Walija, very much. Thank you, Dr. Ayushi, very much. Dr. Mo, thank you very much. Dr. Javira, thank you very much. I guess even I read arthritis as rheumatic, so made a mistake. You see, that's okay, Dr. Ben. Yeah, sometimes do this mistake. It's not actually a mistake, it happens. Sometimes we're the same. So we all do, but we need to focus next time. Thank you, Dr. Shavin. Okay, guys, I believe there are more comments, but that's enough for today. Thank you very much, guys. I was very happy to have all of you today. See you then tomorrow in our private session at 7 p.m. Sydney time to discuss more and more of this concept. Thank you very much, you guys. Have a great night, everyone. Thank you very much. Bye-bye. Bye. Thank you, guys. Bye-bye.